For those of you who have taken the Ultimate ATLS Prep course and are taking the new ATLS version 10 course this year, I'm including some bonus material because I'm interested in your success and I want you to feel completely confident. Those of you who are taking ATLS version 9 should skip this material because you may end up thinking about the version 10 changes on your version 9 test, and I certainly don't want that to happen to you. For those of you taking version 10, there have been some updates and additions that you need to be aware of. This video will highlight these changes. As in prior courses, Chapter 1 is an overview of the entire trauma protocol with emphasis on the primary and secondary surveys. However, in Chapter 1 and throughout the course, there's an increased focus on a team approach and the importance of the trauma team. The fact that resuscitation is occurring simultaneously with the primary survey is highlighted. Keep in mind that the term C-spine immobilization is no longer being used in ATLS. The preferred term is now restriction of C-spine motion. The amount of crystalloid given initially has decreased to a 1-liter bolus, not 2 liters, and the focus is now on giving blood early, and massive transfusion protocols are stressed. Coagulopathy is again a key risk factor, but new to ATLS 10 is the recommendation that tranexamic acid be given within 3 hours of injury. Tranexamic acid is an antifibrinolytic agent that has been shown in the CRASH 2 trial to reduce the mortality from bleeding when given between 1 and 3 hours of injury. However, after 3 hours, it may increase the risk of fatal hemorrhage, so early administration is key with this intervention. There is also a new focus on the Canadian C-spine rule along with the Nexus criteria. Review these prior to your exam. Chapter 2 is not significantly changed from what you are familiar with in ATLS 9. However, the terminology RSI, or rapid sequence intubation, has now been changed to DAI, or drug-assisted intubation. Video laryngoscopy is also being highlighted for its usefulness in difficult intubation. In Chapter 3, the chart detailing the classes of hemorrhage has been updated to include base excess and to utilize the more objective Glasgow Coma Scale score instead of level of anxiety. Take a look at it on page 49, table 3.1. Again, early administration of blood and blood products is encouraged, with only 1-liter crystalloid bolus being recommended prior to blood administration. A massive transfusion is defined as 10 units packed red blood cells in 24 hours or 4 units packed red blood cells in 1 hour. Don't forget to initiate your institution's massive transfusion protocol if indicated on the practical exam. TEG or thromboelastography is being recommended to monitor the progress or resolution of coagulopathy. It can assess the viscoelastic properties of clot formation in fresh or citrated whole blood in real time. As I mentioned earlier, the antifibrinolytic agent tranexamic acid can also be beneficial if given within 3 hours of injury. In Chapter 4, flail chest with pulmonary contusion has been downgraded from immediately life-threatening to potentially life-threatening. However, tracheobronchial injury has been upgraded to immediately life-threatening. Keep in mind that with a tension pneumothorax, the new guidelines for needle decompression use the 5th intercostal space just anterior to the mid-axillary line for adults. The recommendations are unchanged for children. Rapid finger decompression prior to definitive chest tube placement is also mentioned as a potential treatment for tension pneumothorax. You can see this demonstrated on page 66, figure 4.2. For a massive hemothorax, the recommended chest tube size has been decreased to between 28 and 32 French instead of 36 to 40 French. Review the new algorithm for traumatic cardiac arrest found in figure 4.7 on page 71. And as I mentioned in the regular prep course videos, don't forget your beta blockers with patients with traumatic aortic rupture. There's not much change in Chapter 5. However, palpation of the prostate gland is no longer indicated to check for urethral injury due to its inaccuracy in a trauma setting. The rectal exam is still indicated, however, so don't skip it on your practical exam. The flow chart for pelvic fracture with hemorrhagic shock has been amended. You can review it on page 98, figure 5.10. In Chapter 6, the Glasgow Coma Scale has been revised slightly. See Table 6.2 on page 110. However, don't worry if the old scale is stuck in your head, because you'll still get the same score using the old scale. The classification of traumatic brain injury has changed to use the terminology mild for a Glasgow Coma Scale of 13 to 15 instead of minor. Additional emphasis is placed on systolic blood pressure management in the hypotensive trauma patient. It is recommended to maintain a systolic blood pressure of 100 or greater in patients 50 to 69 years old, 110 or greater for patients 15 to 49-year-old, and older than 70. Seizure prophylaxis and reversal of anticoagulation in the management of head trauma are also highlighted. In Chapter 7, the myotome diagram has been redone. See figure 7.3 on page 134. The terminology for protecting the C-spine is now restriction of C-spine motion, because it can't truly be immobilized by basic and advanced life support techniques. There is new emphasis placed on the Canadian C-spine rule and the nexus criteria in evaluating spinal trauma. Please review figure 7.8 on page 139 and 7.9 on page 140. Chapter 8 only has a few changes. Weight-based dosing of IV antibiotics is highlighted. You can see this on table 8.2 on page 158. The increased risk with bilateral femur fracture is also highlighted. A helpful chart can be found on page 161, table 8.3 and 8.4, which highlight the peripheral nerve assessment of the lower and upper extremities. Also review the principles of immobilization for various classifications of fractures, found on page 163. There are also a couple of changes in Chapter 9. Of note, when using the Parkland formula for calculating your fluid resuscitation, instead of a range of 2 to 4 milliliters, you should utilize 2 milliliters of LR times the patient's weight in kilogram times the percentage burn in adults, and 3 milliliters times the patient's weight in kilogram times the percentage burn in kids. As you know, your fluid administration should be titrated to urine output. The goal urine output is 0.5 milliliters per kilogram per hour in adults and 1 milliliter per kilogram per hour in kids less than 30 kilograms. In Chapter 10, needle decompression remains in the second intercostal space of kids. The "don't be a dope" mnemonic is utilized as a reminder for the common causes of deterioration in intubated patients. DOPE stands for dislodgement, obstruction, pneumothorax, and equipment failure. As with adults, crystalloid resuscitation is limited and blood is utilized early. A single bolus of 20 milliliters per kilogram should be given, then start giving blood early. In Chapter 11, the 5 pre-existing conditions that greatly increase morbidity and mortality in elderly trauma patients are emphasized: COPD, ischemic heart disease, diabetes, cirrhosis, and coagulopathy. Remember that in the elderly, pelvic trauma, even a so-called minor fracture, increases mortality by a factor of 4. It also increases length of stay and increases the need for blood transfusion. In Chapter 12, the only significant addition to keep in mind is that vaginal pH greater than 4.5 is an indication of amniotic fluid leak. Chapter 13 is not significantly changed either. However, specific mention is made of avoiding CT at the first hospital if a patient is going to be transferred. Take a look at the S-bar template for transfer communication on page 247, table 13.2. Those are the changes to look out for in version 10. To help cement these updates in your mind, I have also included additional test questions which are specific to the version 10 updates. I hope that this will be useful to you and that you will be successful in your ATLS certification.